Hello, everybody, and welcome to the Master Clinicians podcast. I am your host, Dr. Frank Illuzzi. I serve as the Executive Vice President of Quality and Medical Education at CityMD Urgent Care here in New York City. And today we're going to be talking about malpractice issues around COVID-19. Our guest is attorney Dylan Braverman. He's a partner at Vigorito, Barker, Patterson, Nichols, and Porter, and he specializes in complex civil litigation, has been awarded the designation of super lawyer every year since 2017. He is the president of the Association for Healthcare Risk Management, the largest healthcare risk management association in the state of New York. And Dylan is also a volunteer firefighter in Chappaqua, New York, where he lives. He has also been awarded the prestigious Father of the Year award 3 years running. Dylan has recently been designated the lead COVID-19 litigation counsel for several of the most impacted healthcare organizations here in New York, and as well as a national malpractice insurer. So he is an expert in this area, and we are thrilled to have him here today to talk about malpractice issues around COVID-19. Dylan, welcome to the podcast.
Thank you, Frank. I've always said we both have a great voice for radio, so I think we'll do well on the podcast.
I think we have a great face for radio, but I will only speak for myself on that. Well, welcome to the podcast, and thank you for talking about this. Obviously, you know, we are going through the worst pandemic anybody has seen in over 100 years. A lot of the clinicians like myself on the front line that are seeing COVID patients, you know, we've been just trying to take care of our patients, and we haven't really thought too much of the malpractice issues around that. And, you know, when we had this conversation a little while ago and you brought up many of the issues that we weren't thinking about, I thought it would be a great idea to get them out so the frontline clinicians can have an understanding of what malpractice litigation will look like in a post-COVID-19 landscape. So I appreciate your time, and I appreciate you being here with us today. I was wondering if you could start off by just giving us maybe a background of the state of malpractice, you know, during, you know, the initial phases of the pandemic, how that affected generally malpractice with the courts closing, and then, you know, maybe give us a brief overview of the landscape of what malpractice looks like during the COVID-19 pandemic.
So on March 6, 2020, the landscape looked pretty much the way it looked in 2019. Everything changed on March 7th, 2020. That's when the state of emergency was declared. I think people started taking it a little more seriously. Offices started closing down a few days later. Schools started closing down. And while you guys were out rightfully earning the 7 o'clock applause, we were doing something different. We were forced to go home. There was no longer any litigation was closed. You weren't allowed to start new litigation. And I think from conversations with many of the more prominent plaintiffs' attorneys, they were thinking long and hard about bringing a claim against the doctor. So the prior claims, that's been affected. So if you already have a claim that's been brought against you that's entirely unrelated to COVID and pre-COVID, COVID's going to have an effect on everything in and out of medicine, and law is no different. The glow, if people who are listening were involved, were lived in New York after 9/11, or frankly across the nation, there was a glow on firefighters and police officers, but particularly firefighters in New York were thought of as heroes. That really hasn't faded, but you probably can, if there was something, a reason to point a finger at a firefighter, go to a juror now in 2020 and say, I'd like for you to look at the firefighter and treat the firefighter fairly, but the firefighter did me wrong. In New York in 2020, starting right now, and plaintiffs' counsels have acknowledged it, that glow is now attached to physicians. And that's something that is really scaring the plaintiff's attorney. Another thing that's happening right now is not going to be trial until 2021. I think the summer of 2021 or when trials are going to start to pick up again. What does that mean? If you have a case against you and your attorney or your insurer has told you, well, gosh, block off 3 weeks at the end of 2020, the early 2021, I don't think it's going to happen. The reasons are obvious. People don't want to be in a room together. We're going to have to figure out ways to do trials differently. Another thing that's changed is depositions. If you've been brought in a lawsuit, one of the things, your biggest contribution to the lawsuit as a physician oftentimes is showing up for a deposition. Very few cases actually go to trial, but most cases do advance to the deposition. before the deposition, as you know, you're probably going to spend 1 or 2 days, probably maybe 3 days, meeting with someone like me and going through the claims, going through your chart. Usually we sit next to each other, we look at the chart. Right now, that's not happening because of not just social distancing. You happen to be very busy as a physician. So that's not just in New York, that's all over the country. It's very hard to get a physician in for a deposition. The other thing is that the courts are saying, well, that's fine. We're going to do a Zoom deposition, a Skype deposition, a WebEx. I'm not going to produce you for a deposition unless you and I had that opportunity to sit down, go over and pour through the chart for 3 days. Also not going to produce you for a deposition unless I'm sitting next to you at that deposition. Things are changing now. In New York, we're entering phase 2. And if we're entering phase 2 in New York, what does that mean? That people are already probably a step or two ahead of us in the rest of the country. So I would feel comfortable meeting with my doctor at this point. I would feel comfortable sitting next to my doctor, but other people aren't. Is there a strategic advantage between this whole podcast and you, Frank, of my doctor, myself sitting in a room together and being deposed on Zoom while plaintiff somewhere else? Sure, right? We have a little bit of a remoteness, and plaintiff can't use some intimidation tactics and things that they would normally do in person. So that could work in our advantage. These are just things to think about. Specifically in New York, and it happened all across the country. For instance, it didn't happen everywhere. For instance, in Florida, litigation never stopped. COVID never stopped anything. It just continued unabated. In New York, in New Jersey, other places, it has been relatively stayed. And what we've done is we've told the statute of limitations. It was extended for the 3rd time. Right now, it's extended to July 6, 2020. So if there's a statute of limitations that would have expired from March 7th, 2020 to July 6, 2020, there's an extension. That's an extension of 108 days. It might get told again, and it's told in periods of 30 days.
So I'm sorry, I'm going to interrupt. So what you're saying is the usual statute of limitations, which if I remember, just to refresh my memory, I believe in New York, it was 2 years plus 90 days. Is that the statute of limitations? Plus the 7 years for Laverne, 2.5 years. Okay, so it was 2.5 years. That all got suspended. So if you had a case from 2.5 years ago right now, the statute of limitations for that case is not running out, so that will continue. That just explain that a little bit.
Okay, yeah. So let's assume that your statute of limitations would have expired on April 1st. That is tolled until the toll is lifted. Right now, it's to be lifted on July 6, 2020. So does that mean they have to file the complaint on July 6, 2020? Well, there's some debate. Plaintiffs are going to say, no, I have a 108-day extension, so I go 108 days from that the day that my statute would have expired. I would probably take a more restrictive argument, and that's something that's going to have to work its way through the court. One thing you're going to hear from me a lot today is these things need to work their way through the court. I could tell you how I think they may work out, but this is unprecedented. Just like it's unprecedented in the medical field, these are all things that have never happened before. So at some point, anything in law needs to have judicial interpretation. And what happens is one judge might find it one way, another. Eventually, it needs to go up to the Court of Appeals, and they're going to give a definitive ruling that's going to resolve it. That could take some time.
So regardless, there is an extension of the statute of limitations for all the cases that have happened, let's say 2 years ago. The clock isn't running out on plaintiffs who want to submit. They're going to be able to submit those claims this year.
Correct. And you can file cases now. As of 2 weeks ago, you can start filing cases. Despite the fact that you could file a complaint today if you want to, the toll is still going. The theory being is that we're only in phase 2. Some people might not want to go and do what they need to do to get the paperwork to court, even though you can do everything electronically. So they're still extending the time despite the fact that you can get sued as of today. And
Wow.
cases are coming in. There's already COVID-19 cases that have been filed that are in active litigation.
Interesting. Okay. Well, we're going to get to the COVID cases actually next, so that's a very good segue. As a clinician, again, your audience here are going to be practicing clinicians. They've been seeing COVID patients over the last, 3 or 4 months in the New York metro area and elsewhere. one of the things that we picked up on is, we're listening to the news reports and we're hearing about, immunities, that are afforded both on the federal government side and on the state government side. So, you're saying that COVID cases are already coming forth. I mean, that's concerning to us because we were in the middle of a pandemic. That's the last thing from our minds right now. Is there any way you could start going through some of, the national immunities and maybe state by state immunities? So, let's start with the national immunities. The one that I can think of is the PrEP Act. Maybe you can talk about what the PrEP Act is and, what national protections you have, and then maybe cut back in some of the state immunities. You can go through, some of the executive orders that Governor Cuomo put out.
Okay. Yeah, sure. And I'm going to try to make this in layman's terms the best I can, but forgive me for a moment because sometimes I'm going to have to go a little bit legal on you. So what's going to happen is this: the PrEP Act is a national act that was put forth. Frankly, it's intended to protect the manufacturers of the vaccines, of the ventilators, of what's called a response to COVID-19, or a response to the pandemic. It's triggered when a pandemic is called. Here, as we know, the national emergency was called, so it's triggered. It's in place. So there's very little, and it's funny, we just got done talking about how the law works, and people like to think that there's a law, everyone knows what it means, and we all agree. As you can imagine, I'm going to say the PrEP Act protects everybody. The attorneys for the plaintiffs are going to say the PrEP Act protects a very discrete number of people, and then we're going to argue about it. Judges have to make a determination. There has not been a lot of determination on the PrEP Act for the obvious reason there has not been many situations similar to COVID. So it's intended to protect the manufacturers. What does that mean? That means if you are someone who is putting to market a vaccine, someone wants to bring a claim against you saying the vaccine caused your child to have autism or some other negative reaction, you are protected. If you are the distributor, you are protected. If you're the physician who injected that vaccine or the physician who used the ventilator that later on someone says that ventilator was manufactured in a way that was causing damages, if you're the manufacturer, distributor, the physician, you should have a complete immunity. And there's some intricacies to it that I'll leave out, but there should be a complete immunity. Then you get into the gray area where I'm going to argue that a broader swath of care would apply to the PrEP Act. That's where the rubber is going to meet the road, and we have to bring that forth to the court. As I said, cases are coming in, and these issues are going to start being litigated as soon as today. And I've already started working on some of these cases and thinking of these cases and preparing my arguments to be presented to the court. We're going to have determinations relatively soon. That's the PrEP Act. That's the national immunity. There's, as you guys know, a state immunity here in New York, the EDTPA. There's other immunities across the country. Some states have done nothing. Florida has no immunity specific to COVID-19. New York, New Jersey have two of the more beneficial immunities. The states that have immunities, and we'll use New York as an example because all of them are relatively the same. These are immunities that have been promulgated by the American Hospital Association and other organizations such as this, that when you hear that there's a movement for a national immunity, these are the immunities that have been pushed. In essence, they say you get complete immunity for resourcing, staffing, PPE. You get what's called a qualified immunity for any care related to COVID or any care affected by COVID. We'll get to that in a second. That could be a very broad range where I'm going to say almost every care during the COVID-19 pandemic was affected by COVID. And I can make a very intelligent, detailed argument about that. It's a qualified immunity though, because it does not apply to gross negligence, recklessness, some other legal terms that all boil down to, frankly, the same thing as gross negligence. What does that mean? Well, gross negligence is defined different in every state. So I'm not going to define it for every state, but it's always very similar. It's something beyond ordinary negligence. It shows an indifference, essentially. But the problem is that gross negligence in New York and most states, unless there's a complete obvious lack of gross negligence, the judges are going to allow this to get to the jury. So what does that mean? that means that you don't get a get out of jail card. You don't get to say, COVID, judge, toss the case. The judge is going to say, well, I will toss the case if there's no gross negligence, but I'm going to allow plaintiff to do his discovery to find out if he could prove gross negligence. He's going to get his documents. He's going to get to do the deposition of the physicians or the hospital, and then it's going to go to the jury. The jury's then going to be asked to determine whether it's gross negligence. The jury's going to be told that if you, in essence, not in so many words, if you want to find in favor of plaintiff, you need to find gross negligence. And they're going to do just that. Some juries and some jurisdictions that are going to want to find in favor of the patient will find gross negligence, whether it's there or not. That's the fear. That's why you have to be very aggressive from day one. And you have to start very discreetly, narrowly defining these exceptions. Not narrowly defining, frankly, very expansive or broadly defining the exceptions. Plaintiffs are going to try to do the same.
If that's the case, I'm sorry to interrupt, but if that's the case, that doesn't sound like an immunity to me. If you're immune for everything except gross negligence, and the judge at the onset doesn't say, well, this doesn't meet the standard of gross negligence, I'm going to let it move forward. That doesn't sound like an immunity to me. If they're letting the jury decide, because you're still going to trial and you're still putting yourself at risk, when the jury is going to make that determination of gross negligence. Is my understanding correct?
Well, I'm not going to make plaintiff's argument. And it's kind of inherent. Plaintiff's argument is going to say it is immunity, but we're allowed to, how else can we prove if there's gross negligence if we don't have the chance to look into it? I happen to disagree. I think certain claims are obviously not gross negligence, and the court should step up and say this case is not gross negligence. The problem is, once again, we've never had a COVID-19. We've never had a COVID-19 in immunity. So this is all brand new to the court. And courts like cases resolved on the merits. The courts are going to have to make a decision. Are they going to favor the public policy of having a case resolved on the merits, or favor the public policy that has been explicitly set forth by the legislator and signed into law by the governor of New York, of New Jersey, of Connecticut, of most other jurisdictions that have been hit hard by COVID-19, that we want to set our physicians loose to protect our citizens and provide the best healthcare possible. And to do that, we find that we have to have certain immunities, and that's been articulated by the court. And I could argue that all day long, and I think it's the right argument. I just can't promise you what the court's going to do. Any attorney that promises you what the court's going to do is the same as a physician promising exactly what the course of the patient's outcome is going to be.
Understood. Now, there were several things that were protected by something called absolute immunity, and I believe it was about procuring PPE or staffing or something along those lines. Can you explain what absolute immunity is and what is covered by those executive orders from the governor?
So the absolute immunity, what that means is that the gross negligence is out the window. So if a plaintiff comes and says, Dr. Jones, I'm suing you because you were understaffed during the time of COVID, and he's going to say, I should still get this claim because it's during the time of COVID, there's gross negligence, it still gets dismissed. The gross negligence exception, the carve out, is gone. So anything to do with staffing and resources is absolutely immune. They have no way out. But it's going to be difficult because plaintiffs are not going to put in their complaint, I'm suing you because of staffing. What I've seen from the complaints I've got in is they have to keep in mind the immunities start as of March 6, 2020. The cases I've got in have claims that go back to January. They refer to CMS guidelines that were issued in December. So they're making claims pre-immunity. I would argue that that is just a way to wrap around and get around the immunity, but that has to be tested. I think I have some pretty strong arguments, and I feel comfortable with them, but plaintiffs are going to have an opposite view, and we have to test that with the court. The issue is I could paint almost any claim, and rightfully so. I don't think I'm contriving or inflating the claim into a PPE or staffing claim. I think most claims, in fact, will be PPE and staffing and should be entitled to the absolute immunity. Again, we need to argue that with the court.
My thought process on this, when we had our previous conversation, was, as a clinician seeing patients at our clinics, our volumes went through the roof. I mean, we had clinics where the volume went up 200, 300%, and it was unlike anything we'd seen. And it wasn't just one site; it was all the sites go
Absolutely.
in that manner. My argument would be, if there were any errors, so long as it wasn't willful or grossly horrendous, that that has to be somehow mitigation of some sort for any errors that occurred there. And it seems pretty easy that I could show you what my volume was 2 months prior, and then I can show you what my volume was during the pandemic when it hit. Would that be an argument for absolute immunity for anything that happened during that period?
Yeah, the short answer is absolutely, and I could prove it with just a quick question and answer. I'm assuming it's fair to say that you saw volume spike up for the type of complaints and HPI when people showed up that would normally go to other specialists, right? You saw people come in with pregnancy-related complaints, with complaints regarding that they would normally go to their treating orthopedist, their treating neurologist. They just couldn't go to those doctors.
Or their primary care physician that had all
Absolutely.
their prior records?
Yeah.
Yes.
So as an urgent care physician or an ED doctor, you became the only game in town. People were going to you guys for everything. That's a classic resource and staffing
Okay.
issue. But just so you have to understand, when the cases come in, you can't just have me say it. What we need to do is something a little bit different than we ever did. We need to provide stats. And I think that if you make the argument and have witnesses, because let's face it, I could get national witnesses to talk about it and local witnesses to talk about it. I mean, expert witnesses. But if I have documents to back it up to show that, and we could talk about telehealth in a little bit, but I could show before COVID-19, telehealth was providing 11% of the care in New York and went up to 40%. If I could show that these type of cases came in and they spiked during this time, that would be evidence that I could go ahead and present to the jury, present to the court even before we get near the jury, and we should be able to make a very strong argument for the absolute immunity, which frankly is what we want, right? We all want these cases to be dismissed without having to step any further than saying this is an immunity. You want that get out of jail card,
No,
because that's what I think the EDTPA was intended to give you and the other state immunities.
well, that's very comforting for those of us on the front line. So thank you for speaking to that. Another question that we had along the lines of the executive orders around immunity were the executive order for Governor Cuomo gave in one of his talks about documentation during COVID. Famously, he got on the dais and basically, said to all the healthcare workers on the front lines, "Don't worry about the documentation. Just take care of the patients. That's what you need to be worried about." And so, a lot of frontline clinicians were very comforted for that, because they were being overwhelmed with everything else, and they could concentrate on taking care of their patients. Can you speak to what the protections are for that, and what the risks are for less than normal documentation?
Yes, in a nutshell, ignore what Cuomo said. Worry about the documentation. Document the heck out of these cases. It's a serious thing for malpractice, because no one ever lost a malpractice case because of not following a regulation regarding documentation. But a lot of people lost a malpractice case because they didn't document something that in retrospect should have been there. You have to document as detailed as you can, because cases are won and lost by charting, and you're never going to be able to go and say, well, I didn't need to chart this, so therefore cut me a break. Nobody's going to care. The plaintiff's attorney is still going to be able to hurt you when they say there was a facial lesion on this patient, right? Correct? Yes. How big was it? Well, I don't remember the patient. Well, show me in your chart where it says the measurements of the facial lesion. It doesn't say it there. Okay, well, the patient came back to you 2 weeks later. How much has it grown? I don't know. Well, show me in the chart where it describes the increase or decrease in the facial lesion. You could get the drift, right? We could have a million different examples. You can't say to the jury that my doctor didn't need to chart this. But by the way, I'll take that back for a second. We have a million different arguments, right? And the jury is going to be made aware of the COVID-19 pandemic, and that's going to be an element of the defense. But you're hurting yourself, and you're not being honest with yourself if you think that that's going to be a panacea. It's not going to be. It's going to be very difficult to defend the case if you don't have detailed and appropriate charting. And here's the other thing, and this is important advice, I think, is that if your chart mentions the pandemic in a realistic way, by the way, every patient that walks in, I'm assuming every physician is speaking to them about the pandemic, looking at them in the pandemic, seeing if they have any risk factors for COVID-19, if they have any signs and symptoms of COVID-19, chart that. That does me a huge favor. So when the case comes in, I'm able to use that chart entry to draw the attention to this is a care that was given during the COVID-19 emergency. Then we could do some of the other defenses that we just spoke about, right? We could talk about the volume went from 100 patients a day to 1,000 patients a day. Then all of a sudden, the more abbreviated charting could become very forgivable. And in fact, I can use that to my advantage and make plaintiff look like he's being disingenuous and he's trying to manipulate the jury by suggesting that you should have spent 10 minutes charting things instead of treating the next patient.
That's a good point. So you would encourage us to just document a couple of pertinent positives or negatives in the history of present illness. Let's say, patient not presenting with, fever, dry cough, loss of taste or smell, or any COVID type symptoms, or they are, just by documenting that in the history of present illness, or documenting like on the diagnosis line, the ICD-10 code for potential exposure to COVID patient. Those things will help you in terms of protection by bringing in the COVID defenses and exemptions. Is that what I'm
Absolutely.
understanding? Okay.
Yeah, absolutely. And the reason is obvious is I'm going to be able to draw attention to that. And I believe that the glow that physicians are going to have, especially the frontline physicians like urgent care physicians and emergency specialists, are going to still be there by the time a jury ever hears these cases. By the way, judges are human. By the time the judge hears the case, and the more it reminds the jury and the judge that this was treatment under the time of COVID, the more that they're going to realize that if you attack somebody for doing something that was counterproductive to treating as many patients as possible during COVID, you're basically asking the jury to nullify the heroic efforts of what's going on. And frankly, there's really no other way to say it. Right. What's happening now is unprecedented, and people are putting their own lives at stake to protect the population of not just New York, everywhere, right? So the jury will be aware of that. Sometimes I just might need to remind them.
Right. Well, that's a good point. Thank you very much. Are there protections for the clinicians administering, experimental medications, let's say the remdesivirs or the hydroxychloroquines? I mean, you mentioned the PrEP Act. Is that what's covering us when we're using experimental medications? If somebody happens to have harm from one of these, because there's no real good literature, and the papers that come out get rescinded a week and a half later, and there's a lot of incomplete information out there, and we're kind of shooting in the dark here. What are our protections for trying novel treatment techniques for our COVID patients?
Right. I mean, that's a great question. So there's three. First, you have the PrEP Act, and the PrEP Act would protect any countermeasure to COVID-19. And what you described are by definition, again, I promise to try to avoid legal terms, but countermeasure sounds pretty legal, right? So all that is anything you're doing to attack and to treat COVID-19. Everything you mentioned would be in that category, right? So I would make an argument that the PrEP Act should apply, and that should give you a federal immunity. Then I would make the second argument that you have the state immunity, right? Because this is treatment directly for COVID-19. The state immunity applies to any treatment of COVID-19 or treatment affected by COVID-19. Well, that satisfies both pretty heavily, right? So I think that would apply. It doesn't, I don't think you can make the argument that providing that medication is grossly negligent when the literature is split on it, right? So gross negligence is negligence, which in a medical malpractice term would have to be a departure from standard of care. I don't think you could say there is a departure of standard of care giving it let alone having a heightened state of negligence that you would need to prove for a gross negligence claim. So I think that would be pretty well protected. So that's number one, federal immunity. Number two, state. Number three, let's assume that it gets through those. And I think that as physicians, you'll understand this better than most. I think you could make an argument that there is no standard of care for treating COVID-19. Even right now, today, certainly there was probably very little standard of care on, let's say, March 15th, April 12th, and the standard of care changes day by day. I have compiled, at this point, it's around a 40-page second-by-second list. As you guys know, some days you could have given a patient Advil at 1 o'clock, and then you get guidance at 2 o'clock saying, don't give the patient Advil. So it's going to be important, right? The case comes in, I need to know, well, at 1 o'clock, they were still giving patients Advil. At 2 o'clock, they weren't. When a patient's on a ventilator, should be in their stomach, should be in their back. This is a young patient. At one point, young patients have nothing to fear of COVID under certain guidance, right? Now we know better. Some people are even denying that to this day. So I would make the argument that there is no standard of care, and it's a minute-by-minute standard of care. What was happening in Staten Island might not be the same thing that might be happening in Suffolk and the same thing that's happening in Brooklyn. So I think it's a very localized, small locality of standard of care that might apply just to Brooklyn, to the Bronx, minute by minute, day by day. And I think that, I don't want to give any tips to the plaintiffs bar, but I think that plaintiffs are going to come in broad, and we're going to be very successful in getting some of those claims. We're going to be very successful in dealing with some of them.
Very good. Very good. More broadly, just moving forward, like you said, we're entering stage 2 and things are starting to open up. What do you see as the future of malpractice, in the coming, months, and what do you predict in the coming months and years?
Well, I think that, like I said, we've been able the courts have been open for filing for 2 weeks. I personally have more than a handful of COVID-19 cases that have already come in. Nursing homes are going to be heavily involved in litigation, but a lot of them are physicians and hospitals that are already coming in. So it appears to me what's happening is that some of the larger, more well-funded and well-equipped and aggressive plaintiffs firms are jumping into COVID-19. And it seems like some of the smaller firms are jumping into COVID-19, but the vast majority in between, let's say the top 10%, the bottom 20% are jumping in. Everyone else in between is taking a wait and see. And when I've spoken to the plaintiffs' attorneys, they say, it's not for lack of cases. People are calling me. I just don't know if I want to take these cases yet.
Gotcha.
And it all comes down to what we talked about earlier. If the judges make certain rulings that are favorable to us, the cases, for the most part, are going to be kept at bay. If the judges don't, then obviously the immunity is watered down. That could be a problem. Just a note, is out in the news today. There's already some assemblymen trying to get rid of the immunities in New York altogether, and not just in New York, everywhere. Conversely, we know that there's people pushing for a national immunity. So it's still, the whole thing is a little bit up in the air. I think that litigation is going to be changed generally by COVID-19 forever going forward. The same way lots of things will be changed forever. But that's also something that we're going to have to wait and see. I think that it's going to be less trials, probably more mediations. But as far as physicians, I would just watch the news and see what happens, because I think that we have to wait and see what's going to happen as far as a flood of litigation.
All right. Well, parting words, any words of advice for the frontline clinicians? Is there any 1 or 2 things that you would have them do or not do moving forward to make your job a little bit easier?
Hug your wife, kiss your kid, go, put on a baseball mitt, and then maybe we'll get to go to Yankee Stadium one day and get some sunshine, because I think that it's fair to say that my doctor friends have done their share, and you deserve a respite. I'm sorry to say, I think I've heard from you that it might not be coming anytime soon, but I hope that you can. And, I know that you're off this weekend, and then enjoy it. Enjoy your beautiful family.
Well, my friend, thank you very much for your time. I appreciate it. Thanks for everything that you do for us clinicians on the front lines. It's nice to know we have somebody with your brain power behind us as our backstop. So thank you for the words of advice, and thank you for speaking us today. I appreciate it. So
My
uh,
pleasure, Frank.
for everybody on the podcast, I hope that that was helpful to you. If you have any further questions, obviously you can send that into masterclinicians.com. I'm sorry, masterclinicians.net, and we'll be happy to get back to you about that. But until next time, this is Dr. Frank Illuzzi signing off.